welcome everybody. So nice to see you all. On behalf of the Center for Spirituality and Health at the Icahn School of Medicine at Mount Sinai, I welcome you to our Grand Round series. I was thinking recently about the various aims of the Center for Spirituality and Health, and while we haven't taken the opportunity yet to really write those down in a hard and fast way, I think it's safe to say that we're aiming to advance the evidence-based practice of spiritual care. And nobody has done that more than our guest speaker today, George Fitchett. He's probably someone who does not need much of an introduction for this community, but I will tell you that he is a professor and director of research at the Rush University Medical Center in Chicago. Most recently, as you probably know, he and Dr. Wendy Cadge have secured a $4.5 million grant from the Templeton Foundation to transform the chaplaincy profession by integrating research and helping us all to become research-informed practitioners, if not evidence-based practitioners. He's a board-certified chaplain, he's a CPE supervisor, he has a PhD in epidemiology, and I think anytime I do a PubMed search, somehow his name pops up in an article about every week that's published. I don't know if he's the most prolifically published person in our field, but he's certainly close. And so we are absolutely delighted to have him with us today to talk about developing evidence-based models for screening for spiritual needs. So without further ado, Dr. George Fitchett.
Thank you, David. It's wonderful to be here. What is happening here at Mount Sinai with the Center for Spirituality and Health is really very exciting and very important, actually, in terms of advancing evidence-based approach to chaplaincy care. So we're really counting on you to become leaders here, to continue to be the leaders you are, and it's really a pleasure to be here with you. So I'm going to fill a little time while we're getting the technology working. It's also a pleasure to be here, actually, because I was born and raised in Queens, and so come back home. Always nice to be back here. I'm happy to make the slides available to anybody who's interested in them, and I can also make available a bibliography so that every reference that you see in the slides, if you want to follow up on it, I'll make that available. So I want to bring you into the middle of a conversation today. So sometimes when I speak, I do kind of the introduction to evidence-based approach to spiritual care. But you're beyond the introduction here. So I want to bring you into the middle of a conversation, and that is to think with you, how do we develop evidence-based approaches to being sure that the patients who need spiritual care are receiving it? Okay, so that's the question. And I would say right now that kind of the bottom line here is that in our profession, it's not clear we have the best approaches to being sure that the patients who need our care are receiving it. So I want to show you kind of our current approaches, point out some of the limitations of those approaches, and then quickly kind of suggest what I think we need to do to kind of advance an evidence-based approach to spiritual care, but get your conversation and feedback about that. Does that sound all right? Okay. So kind of begin by talking a little bit about some research about who does and doesn't receive spiritual care, then talk a little bit about the ways in which we find patients who need us and the strengths and weaknesses of that, and then, as I said, invite you into some conversation about how do we kind of strengthen this and do it better. So in terms of objectives, there they are. I'm not going to read them to you. You can kind of see. So this is where I want to begin, and I want to spend a minute with this. These are data from a study of 330 patients who were receiving acute rehabilitation for traumatic brain injury. They were being treated at 3 different acute rehabilitation centers, 2 in the United States, 1 in Canada. These 300 patients are part of a larger study of 2,000 patients receiving acute rehabilitation for traumatic rehab in 11 different centers. The project used what's called a practice-based research methodology. in which essentially they gathered. Okay, you know, I'm just going to use the podium, and then we don't have to fuss. Thanks. The project used what's called practice-based evidence methodology, in which exquisite detail about all of the therapy that the patients received from everyone on the treatment team was recorded by the professionals who were providing that treatment. And the chaplains at the 3 different centers created an important kind of data collection form to report the care that they provided to the patients. So you'll see overall, when we asked the question of all the patients who were in the study, who were in one of these 3 hospitals, how many of them had any spiritual care? And you'll see the answer to that question is 58%. And it varied. Look at the variation. At one of the U.S. hospitals, 90% of the patients had at least one chaplain visit, and at the Canadian hospital, it was 42%. And Goldilocks was in the middle there, right? Okay. So begin to think, what do you think explains who received any care versus who received none at all? So that's the first line. And then the second data is among those who received any care, what was the total number of minutes of care that they received? And the important figures to pay attention to are down here, because some people were in rehab for 1 week and some people were in rehab for a month or more. So people who were in rehab for a longer period of time had a longer opportunity to receive some chaplain care or to receive more minutes of chaplain care. So the last line adjusts the total minutes, which are here, by the week of rehab. So overall, about 30 minutes, but look at the range. From less than 1 minute to over, what's 22 divided by 60? Right? A lot of minutes. That's several hours of chaplain care, right? And then these are medians, actually, by the way, not averages, right? Because of the fact that there's some people who are getting this huge number of minutes, it makes an average not a very helpful figure. So we use the median, which is the 50% point. Half the patients got more minutes, half the patients got less than the median, right? And then you'll see the differences in the medians. The 2 U.S. hospitals were somewhat similar, but the Canadian hospital was much lower. So again, some important variation. If you receive spiritual care, the amount of spiritual care you received varied considerably. So one of the points of the study was to see whether or not we could find things that were associated with the variation. We might call them predictors. All right, so what's your guess about what would predict who received any care versus not at all? Any guesses?
A referral from another healthcare provider.
A referral from another provider. Thank you.
The patient request on their own.
Patient made a request.
How religious they were?
How religious they were? Yes?
The efficiency of the hospital system in passing referrals.
The efficiency of the system
Communication.
in making the referrals. Yes?
Number of chaplains in the department?
Number of chaplains in the department, yeah. 1 or 2 more.
And related to that, the size of the hospital.
The size of the institution, yeah. The caseload, in some sense, right?
The complications of the diagnosis.
How sick was the patient? Right, yeah. So we had information for about half of the things that you've measured that we were able to look at. It looks like, so we didn't have information about referrals and things like that for the patients. The first question, patients who received any care versus none. But we had lots of information about how sick the patients were, how long they had been in acute care before they got to rehab, And we had information about the chaplain's workload over and above their responsibilities in the TBI rehab center. And what seemed to be the strongest predictor of whether or not somebody got any care versus none at all was actually the chaplain's caseload. So in the U.S. Institution 2, where 90% of the patients received at least one chaplain visit, that chaplain had no other clinical responsibilities, so was able to be there and meet every patient. And in the Canadian hospital, the chaplain was the manager of the healthcare system. There were 4 other hospitals, including the rehab, and it was a miracle he got there at all. When it comes to the patients who received any chaplain care, we then have chaplains' assessments that we can begin to bring into the picture to see whether or not the chaplains' assessments are predictors. We also have, again, the severity of the patient's injury and condition, and it turns out that, and demographic information, men and women, younger and older, et cetera, high education, low education. Turns out none of those factors are predictors of the extent, the number of minutes of chaplaincy care. Not how seriously ill the patient was, whether the patient was depressed or not, whether or not the chaplain rated the patient as being more religious or less religious, whether or not the chaplain rated the patient as having more or less spiritual distress. So that's the kind of current finding. We're kind of in the last stage of the analysis of that, and in the next few months I'll be writing it up. The next piece that we'll actually do with this analysis is then to look at, among the patients who received any chaplain care, is chaplain care actually associated with better rehabilitation outcomes? We haven't had a chance to do that, but the study, because of the nature of the study, there's actually wonderful information about that. We'll be able to look at it. So when I tell you that among all the things that we measured, none of them help us understand who received any care or how much care they received, what do you think about that?
Well, it makes me wonder what does determine influence.
What does predict who we're spending our time with? And if you ask that question, then what would your guesses be?
People who are already religious and just well disposed to a visit.
People who are already religious, well disposed to the chaplain's visit, more likely to have received the chaplain, been glad for the chaplain's visit, more likely then for the chaplain to have gone back and seen them more. And so it's an important possibility, and unfortunately we didn't measure it in the study, so we can't put it into the equation. Please.
Kind of intuitive triage about who might be.
Intuitive triage. Say more about what intuitive triage looks like. I love it.
I read the chart, or in rounds hear about this patient, and then triggers are set off in me in terms of, this is a room I want to go into.
This is a room I want to go into. So if we had more time, we'd actually sit down with you in a cognitive interview and kind of ask you to tell us more about that intuition, because when we talk about intuition, it sometimes seems like intuition is mysterious. There's no way to penetrate it. But one way to think about intuition actually is trained people observing information very quickly and making decisions based on that. And so it would be interesting to know to what extent what the information is that you're observing very quickly to help you make that intuition, and how that's similar or different than other people similarly experienced in their intuitions.
Yeah, I would think that the perception of distress.
The perception of patient distress, yeah. And so insofar as we could measure it, it turned out, we could measure physical need in terms of severity of their injury. And those of you who work in rehab know about FIM scores. We had cognitive and motor FIM scores, and a very comprehensive severity index, as well as measures of anxiety and depression. They weren't predictive, but there may be some other kind of distress that we didn't have opportunity to measure.
Yeah, people who seem, patients that seem ripe or ready for a spiritual deepening or reorientation, basically. That's intuition.
Yeah, well, it's assessment, isn't it? It's actually after the visit I have some sense that there's a kind of a spiritual need and a welcoming of spiritual care, and therefore I prioritize this patient for subsequent care. So it could be an important possibility. I'm going to kind of move it on. So I would say, insofar as we could measure important factors in this study about need that might be predictive of the need for spiritual care, we couldn't find any. That the kind of most obvious thing was what the chaplain's caseload was. And then beyond that, there was probably something about the patient's receptiveness to chaplain care that predicted the larger extent of care. And in these patients who are the real outliers here with huge numbers of minutes, there probably was some intense kind of distress, and our measure of distress didn't pick it up. But for me, the study does kind of suggest that it's not clear that we're seeing the patients who need us, that our intuitive screening processes may be working somewhat well, but as a profession we may need to get beyond that. So these are data from a national survey of palliative care chaplains. It was conducted last February. People who worked at least 15% time in palliative care, who were members of any of the National Chaplaincy Associations, APC, NACC, NJC, VA chaplains, were invited to participate in this study, and some of you may have actually done it. It was a web-based study. And we had 382 chaplains who are full-time as chaplains, and at least 15% time in palliative care responded to the survey. And one of the things that we asked them was, what are the common triggers for getting you in a patient room? And so you'll see the most common triggers, so that there's kind of, you know, to what extent was it often, frequently, or always the case that one of these things was actually a reason why you went to see a patient. And so staff referrals play a big role in who the palliative care chaplains are seeing. Protocols play a lesser role. Then there's all of this, you called it intuitive screening, and we call it chaplain case finding. All the different ways in which we try to pick up information from the chart, from the nurse, from the medical records to decide how we prioritize who we should see. And then patient family requests also do play a role, but a smaller role, actually, in who we see. And I want to use this set of categories, actually, then, to kind of think with you about the factors that guide who we see, and what is it we know from the research about the extent to which those are working well for us or not working well for us. So these are data from the Healthcare Chaplaincy's very big project, the Metropolitan Chaplaincy Study. So they had, you know, any chaplain who saw any patient in a 2-year period of time in one of 11 hospitals here in New York City. Had to keep track of that visit and report referrals. And so when you do the analysis about where did the referral come from, in 3/4 of the cases, it was that chaplain intuitive screening. It was that chaplain case finding. And we don't know what's underneath that. It's a mystery. And it turns out that that proportion is actually very similar to the proportion that you all reported in your study of patient-family satisfaction with chaplain care, that you reported that 74% of your visits were chaplain-initiated. So patient-family requests are a small part of the pie. The staff are a smaller part of the pie, and as we all know, nurses provide the most, among all the staff, they provide an important part of the referrals. So are we relying on referrals to help us determine who to see? Probably depends on the units we're working on, the institution we work in, et cetera, but when you put it in the aggregate, huge proportions of our cases are initiated by us. Same data, when the referral came from a patient or a family member or a staff member, then there was some drilling down to what were the reasons that had been recorded by that person for why the person made the referral. You'll see families and patients were most often requesting some kind of religious ritual, and the staff were making referrals for patients who seemed depressed, lonely, anxious, where the patient condition was making a change for the worse, or some religious rituals there. So are we seeing the patients who need us? And who, when the staff is deciding what it is they need a chaplain for, and when the family is deciding what it is they need a chaplain for, there's a little bit of a difference. So these are data from a study we did a number of years ago at Rush. We talked to 200 med-surg patients and said, would you like to see a chaplain? And about a third of them said yes. And then we asked them a bunch of other questions and to try to see whether or not there were factors that were associated with who wanted to see a chaplain. Older people were more likely to request a chaplain. More religious people were more likely to request to see a chaplain. And here we had a little bit of information about the kind of stresses that were occurring in the person's life. And it turned out that when stress was high, the people who were highly religious were more likely to ask for a chaplain than the people who were less religious. The rich get richer, and the less religious who may need chaplain care are not asking for it. So in chaplaincy in general, I think it's fairly well established now that asking patients if they want to see a chaplain is not a good practice because it's actually getting people who actually are coping well, for whom religion is important and they appreciate the support. So it may be important for satisfaction scores actually to be able to provide some spiritual support for those people, but you may not need the most experienced, highly certified chaplains to do that, to provide that spiritual support. And so then the question is, patients who are in the midst of some kind of religious struggle, spiritual pain, et cetera, may not be the people who are asking for us. And so how do we find them? I love this study. Some of you may know this study. These are data that were collected in 364 oncology outpatients in Israel. Right? Spiritual care is not as well established in Israel. Mike Schultz and his colleagues in Israel are trying to kind of advance spiritual care in healthcare in Israel, and they're trying to make use of research to help them do that. And so one of the things they did was ask a whole bunch of oncology outpatients, how open would you be to a spiritual caregiver visit? And you see about a quarter of the patients said they were definitely interested, and over 50% were unsure or pretty sure they weren't interested. So what are the predictors of who said they were definitely interested? Who's more likely to say that? Well, it turns out that these oncology outpatients in Israel are the same as the med-surg patients in Chicago, right? Is that people who are more religious compared to less religious, people who are more spiritual compared to less spiritual, had greater odds. An odds ratio of 1 means nothing's happening. An odds ratio greater than 1 means there's an increased likelihood that that factor is predictive of what you're looking at here. So compared to the not spiritual at all, the very spiritual 8 times more likely to say they would appreciate a chaplain, a spiritual care visit. But the piece that I love is actually if people had no experience, compared to people who had no experience with a chaplain, people who with a spiritual care provider, people who had experience with a spiritual care provider were 4 times more likely to say yes, they'd be open to a spiritual care provider. What does that tell us? Some of you have heard Steve Nolan speak. He was at the APC last year. Steve Nolan is a UK hospice chaplain who's written this wonderful book about spiritual care at the end of life, and the chaplain's hopeful presence, and he has 4 stages of chaplain presence in the encounters with patients. And the first stage of chaplain presence, he calls it evocative presence. It's all the feelings that come up for the patient when I walk in the room and I say, hi, I'm George, your chaplain. I'm sorry, how do I say it? I say, hi, I'm George, I'm a chaplain here, can I be of help to you, right? And how is that similar or different than if David walks in, or if Jill walks in, or one of the other of you walk in, or if you walk in wearing a skull cap, or you walk in wearing a clerical collar, all of that evocative presence, right? So all the things that religion and spirituality have meant to people, for better or worse, is part of what happens when the nurse says, do you want to see a chaplain? But when the patient has prior experience with a spiritual caregiver, that changes dramatically. What does that tell us? I think for the most part it tells us we're doing a good job once we're there. And people get to meet us and discover that we're good listeners, we're helpful, we're compassionate, we're not there to preach, to judge. So it's a wonderful study. So here's a summary of the major ways that we make decisions about who to see. We have protocols for a whole different host of situations. Different institutions have different protocols. We have protocols related to crises. We have protocols related to transitions in care. We may have protocols related to other specific situations. So a lot of us are using these. Those of you who have seen George Hanzo's publications about best practices in spiritual care know that he recommends that it's actually probably not a good use of our time to go around doing a lot of case finding, and that it's a better use of our time to have clear protocols so that our staff colleagues know when to call us, or that sometimes it's automated in the chart and certain things are being recorded in the chart and there's an automatic trigger to the spiritual care department. I think he's probably right about that. I think the more clear we are about protocols, the more thoughtful we can be about who needs our care, or at least who needs an initial visit from us, and then we can prioritize our care. Unfortunately, what's true is that there's no research about any of these. We don't know if they're working. We are recommending them, but it's an important area for research as to whether or not using that protocol gets us to the bedside of people and patients and families who most need us, and whether or not it's then having an impact on important outcomes like coping better with crises or end-of-life transitions, all of which we could do research about. And now that we have great centers for spirituality and health, such as yours, we'll put it on our agenda and do it. So the other approach that we have in addition to the protocols is we do have some screening, right? So what do we mean by screening? Screening would be one or two simple questions that we ask everybody in a kind of all new patients that can be asked by non-chaplain healthcare colleagues. And so out of all the patients who get admitted to a unit, out of all the patients who come through an outpatient clinic, we can actually then have some reliable and informative way to allow them to tell us who they are, what's going on for them, and whether or not then a spiritual care visit or referral is indicated. So the screening tool that's most widely known is the distress thermometer, developed by Jimmy Holland and colleagues here in New York at Memorial Sloan Kettering, widely used in cancer care, and actually mandated. So now if you are a Commission on Cancer accredited cancer program, beginning 2015, it was mandated that every clinical encounter there's actually an assessment of distress, and actually an assessment of among, not only physical distress, but it actually includes an assessment of psychosocial distress. And psychosocial is defined to include spiritual distress. And not only do you have to screen for it, then you have to also be prepared to effectively provide care for people who demonstrate that they have distress. So that's very important kind of guideline, clinical guideline, not only for the cancer patients and their families and for the staff, but it actually includes us in a way that hasn't been true in too many cases. So those of you who know the distress screening tool know that patients initially asked the thermometer kind of to say where they are in terms of distress, 1 to 10, 0 to 10, and then to check off the places where they have potential distress. So look at all the potential kinds of physical distress that patients can be experiencing, or practical problems. And spiritual concerns are there. And it's yes, no. And so my colleagues who work in oncology who use this say it rarely checked. In part it may be rarely checked because patients don't know exactly what it means. They don't know whether or not what they've been thinking is actually qualifies for a spiritual concern that they should check with. So there is an initiative in Chicago actually to add 2 or 3 examples here. And it'll be very interesting to look at the results from that initiative to see whether or not that helps patients tell us when they're experiencing spiritual distress that we can then be attentive to. So there are a few other spiritual screening tools. One of the ones that's important was developed by Katerina Mako. I don't know if everyone knows Katerina. You should raise your hand. Katerina is here, and she works for the Diocese of Long Island right now. The data originally came when Katerina was talking to patients at Calvary Hospice I'm sorry, I should have changed this, it's Calvary Hospital. She asked them the question, are you experiencing spiritual pain right now? That is pain that's deep in your soul or being that's not physical. And it can be a yes-no answer, or it can be a 0 to 10 answer. And in Katarina's initial work, 61% of the patients said yes, with an average score of 4.7. So this work has been picked up by colleagues at MD Anderson, and they've used it both with patients and patient caregivers. And we see 44% of patients in an outpatient clinic screen positive for potential spiritual distress. So these screening tools are actually very important to kind of be aware of, to put into practice, and not only to put into practice, but then to conduct some research around them. Some basic research such as this, in which we collect information about the proportion of patients who are reporting spiritual pain, but then also information in which we're reporting the correlates of spiritual pain and whether or not spiritual pain is associated with other known measures of distress, such as poor quality of life or emotional distress or things like that. Some of you know that my colleague Jay Risk and I developed a screening protocol at Rush a number of years ago to try to screen for spiritual distress. We begin by asking the question, are you experiencing religion? Is religion or spirituality important to you now as you cope with your illness? If they say yes, then the question is, how much strength and comfort would you say you're getting from spirituality or religion right now? If patients say all that I need, we assume there's no spiritual distress. And the next question is, is there anything we can do for you? Would you like to see a chaplain? But if patients say, well, I'm getting somewhat less strength and comfort from my spiritual religious beliefs than I need, or none at all, then we think that that's a red flag for potential spiritual distress. And our recommendation is actually there's an automatic referral to a chaplain. Now, we don't ask, would you like to see a chaplain, right, for the same reasons we've already discussed. But what's important in the protocol, actually, in clinical practice, is this group. If the group says, is religion or spirituality important to you as you cope with your illness, and they say no, does that mean that's a happy, well-adjusted atheist who's coping well with their illness? Or some of them are, actually, right? But are there other people who actually have been hurt by religion? It's a source of pain. They don't want anything more to do with it. And it's a little harder in a screening context, where this is a non-chaplain staff colleague who, who's doing a lot of other screening. Do you wear seatbelts and things like that? What kind of question can we kind of ask that will give us some sense of whether or not the potential religious struggle? So the question we came up with was, well, it's not important now. Was there ever a time when it was? If somebody says yes, that's the second red flag for the automatic referral. So it enables us to kind of identify three groups of patients. Patients who are not necessarily going to ask for spiritual care, but potentially need it, because there's possible religious spiritual struggle there. Patients who are not particularly experiencing spiritual struggle, but would appreciate spiritual support. And then a third group of patients who are not experiencing struggle, presumably not experiencing struggle, and who don't have any interest in spiritual support. And if we could actually reliably sort people into those three groups, we could be a lot more efficient and effective in the use of our staff time. So up until today, we haven't had any information about whether or not those protocols are really working. But Stephen King, whom some of you know at the Seattle Cancer Care Alliance, actually administered a survey to 1,500 survivors of bone marrow transplant, hematopoietic stem cell transplants at the Fred Hutchinson Cancer Center. And it's a very unusual sample. These are people who have had bone marrow transplant in the last 2 years, or 10 years ago, or 20 years ago. More than half of them are 10 years ago. So these are not only long-term survivors, these are very long-term survivors. So the experience of religious spiritual struggle in a sample like that is a little bit, it's in some sense the first study. We haven't known what proportion of people in a sample like that would report religious spiritual struggle, and the answer is 14%. And we determined that using Ken Pargament's measure of negative religious coping, 7 questions about whether or not you're feeling abandoned by God or forgotten by God or punished by God. Not necessarily the best measure for spiritual pain or spiritual distress, but in some sense the best we have now. And so that was our reference standard, because you can't determine what technically is called the validity of a screening protocol unless you have a reference standard that you somehow are comparing the screening protocol to, right? So I can't know whether or not the Beck Depression Inventory is a good way to measure depression unless I have actually a psychiatrist who's interviewed the patient and who can tell us whether or not the patient's depressed. So that's my reference standard, and then I look at the Beck Depression. So Stephen actually had 6 different screening protocols in addition to Pargament's questions. The paper's under review right now. We hope be accepted for publication shortly. And so, Katerina, unfortunately, he didn't put your question in there. He didn't know about it when he launched this 2 or 3 years ago. But here's the Rush protocol. So the sensitivity of the Rush protocol is 42%. What does that mean? That means of the 14% of people who definitely had spiritual struggle, according to Pargament's question, the Rush protocol found 42%. Not good enough. Of the people who didn't have struggle, according to Pargament's measure, the Rush protocol correctly said 81% didn't have it. So the specificity is better, but the sensitivity is terrible. And you'll see, so here's the distress thermometer, the NCCN distress thermometer. Of all of them, it actually did the worst. Right, 1 out of 4. Right, and the best was a question that Stephen and his colleagues made for the purposes of the study that they use sometimes in clinical practice. Do you struggle with the loss of meaning and joy in your life? And that had sensitivity of 60%. So we're making progress by developing screening protocols, but none of them are really have the level of validity that we'd like to see. So we've got to kind of go back to the bench and do a better job. You can combine screening items and create what's called the net sensitivity of 2 items. So if somebody's positive on either item A or item B, they're considered positive. And so if you use these first 2, do you struggle with the loss of meaning and joy in your life? Do you currently have what you would describe as religious and spiritual struggle? The net sensitivity for those 2 items together, positive on either one of them, is 80%, which is really beginning to be good enough. But it's also a little bit more complicated to actually have to ask 2 questions. So here's kind of a summary. And this is just meant not to be definitive, but to be illustrative. For good screening purposes, for good case-finding approaches, for good protocols, we want them to be reliable, we want them to be valid, we want them to be clinically useful. So those are very specific kind of empirical assessments that we can make about a particular protocol. And I just showed you how to look at validity for some. And if you really are a measurement geek and you can't get enough, you want to go to this Cosman website. It's out of the Netherlands, but it really is kind of a great website for measurement in health-related things, and it's great for us as well. So our miscellaneous protocols, no research about any of them, so we don't know how good they are. The NCCN distress thermometer, we don't know about reliability and clinical usefulness. The validity is not as good as we want it to be. Katerina, you're kind of in the same boat. If we put you there in terms of how much research has been done about your screening item, we have a little bit of evidence about validity, a little bit of evidence about clinical usefulness, but we certainly need more. And the Rush screening protocol the same. We really are. One way to think about this is that we're in the early days about developing evidence-based approaches to screening and assessment. So I think this is the last slide, is it? Yeah. No. It will be. So this is what I think is the program that we need to follow. I think to do a better job in developing protocols and screening protocols, we need more research about the religious and spiritual needs of particular clinical populations. So then we build the screeners so that they help us find those people who have high levels of spiritual need. And then we test the screeners so that we can be sure that they're actually reliable, valid, and clinically useful. And we've got some beginning good work on religious and spiritual needs of specific clinical populations. One of the important things that's happened for us in our efforts to develop an evidence-based approach to our work is that a lot of colleagues have been doing research about religious and spiritual needs of different clinical populations. And so we have some of that literature to begin with for oncology patients in particular, for patients at the end of life in particular. For the rehab, the TBI rehab patients, it turns out we don't have much good work there. CHF, we have a little bit. But there's a lot of clinical areas where we need to kind of do the lit review, bring the literature together about what we know, or actually begin to do the work. So part of what you hear me saying is that I don't think one size fits all. I don't think we can have one screening tool that works in all the areas that we work in. I think the screening tool in mental health, behavioral medicine, will not be the same as the screening tool in palliative medicine. It will not be the same as the screening tool in the ICUs. It will not be the same as the screening tool that we'll need in outpatient contexts or acute rehab contexts, or as we do more and more kind of moving healthcare into medical homes, and we think about population healthcare and helping people stay as well as can be in the community and in their home. What kind of screening tools do we need to think about how we think of which of those patients there need our help? So all of those contexts, we'll probably have to kind of do this work separately in each of those contexts. So that's a big job. You know, we need not to be discouraged. Research is incremental. We proceed bit by bit, slowly by slowly. We get strong centers for research about spirituality and health, such as yours, and they begin to build programs of research. And over the next several years, I think we'll be able to make great progress in kind of developing stronger evidence-based approaches so that we can be sure that the patients who need us are receiving our care. And that we can build on the strong intuitive screening that chaplains have been doing for decades, and be able to then say, not only do we have strong intuitive screening, we also have strong empirically based protocols that help ensure that we're seeing the patients who need us the most. So because we want to have time for conversation and questions, I'm going to stop there and see what you think. Comments, questions? Dr. Marin.
Thank you so much for coming, and what a great turnout. I'm really glad so many folks are here. I'd like to meet some of you in the audience too, after your work. I think one of the issues that we're challenged with here is operationalizing things. For example, we do have 2 questions from your protocol that nurses fill out. You know, is it important to you, or are you in distress? And we haven't yet analyzed the data, but I can tell already it's not capturing a lot of people. Just by, I've seen thousands of consults already. The thing is, who's going to ask the question? And that's something in terms of the workflow in the acute care patient setting we're struggling with. We have a lot of motive, we want to do things, but even before we test the question, who's going to do it? Should it be the chaplains to do it, to figure out what to do? It's very hard to integrate with other people here because everyone's so busy.
Everyone heard the question, right? I mean, so how do you take something like the Rush Protocol or Katarina's question, or another question that sometimes is used was kind of proposed by Karen Steinhauser, palliative care researcher at Duke, just simply the question, are you at peace? And some very interesting findings just been published actually about a question similar to that, predicting survival in congestive heart failure patients. Actually, those who are more likely to say they were at peace were surviving longer, even when you statistically adjusted for a whole bunch of other things that are associated with cardio CHF mortality. So, yeah, I don't have a great answer, Deborah, as to how you get this operationalized. I think that having chaplains ask the questions actually defeats the purpose, because part of what we're trying to do is to use the questions to triage who we see, so that that's not the best approach. And I think in part we need people who do manage to get it into a protocol to tell us, okay, what were the factors that helped you convince the nursing leadership to to put this in and make it mandatory. So Jill, I don't know if you want to comment on this at all. Jill has gotten it integrated at Memorial Sloan Kettering. Brent Peary at Memorial Hermann led a team. Memorial Hermann is in Texas, led a team that actually got the RUSH protocol implemented as a mandatory part of a nursing initial assessment at 12 hospitals in the Memorial Hermann system. He's a miracle worker, and we need to ask him. And actually, Brent and Jill and my colleague Pat Murphy are doing a panel about exactly this question at the APC meeting in June. Do you want to comment, Jill, as to how you managed? You said earlier you snuck it in, but maybe there was something more than that.
Yeah, I admit to kind of being in the right place at the right time, just as the nurses were working on their assessment tool and thinking, how are we going to make this electronic? So I happened to be sitting at the table and said, ooh, at the end of the conversation. It is difficult to operationalize it, and George, I think you and Stephen King wrote an article about who the best people are to do it. You had medical students doing it well, they only did it about 3% of the time. Other people doing it, and really the nurses are the logical people to do it. The RUSH protocol just fits 3 screening questions in the middle of our electronic inpatient nursing assessment that is done on admission and with any major change in the patient's condition. So I'd like to say we did it once, this is what we found on each admission, but because it's done when there's a change in the patient's condition, the data is kind of messy. But getting it in a screening tool that's already part of what's happening is the best way we found to operationalize it. We're trying a pilot right now, putting a modified RUSH protocol into the outpatient screening, because we find our outpatients are 70% of our population, and we haven't been able to touch them, but we're getting some mandated referrals now through that, and having the mandated referral is the best way for us to move forward.
You have a best practice to learn method, but I think the outpatient is very important to consider, because most people we treat now really are outpatients. They're inpatients 4.7 days, unless it's a change. But that's necessary.
We're down to 2 minutes here.
2 questions. One, is there any research on volunteers like Catholic Eucharistic ministers doing a screening? Because they have,
There's a report, but not research. So actually, probably 10 or 15 years ago, Paul Derrickson, who was at the time the manager for spiritual care at Hershey, is now retired. But Paul actually recommended use of trained volunteers to visit all new admissions in the afternoon and evening, and say, want to say hello as you come into the hospital. I know it can be a difficult time. Want to let you know that there is a spiritual care department here. Here's the brochure. If there's anything we can do to be of help to you, please let us know. And to kind of draw people out in a little bit of a conversation if they were at all interested, and based on that conversation to have an intuitive assessment actually, and then make referrals to the staff chaplains the next morning based on that. So he reported it, reported that it worked well, but there was no research about it.
And my second question is, what about the children?
Yeah, it's not an area that I work in. It's so hard to figure this out for cognitively intact adults, that all the special needs are around pediatrics, adults with cognitive impairment, patients with psychotic illness. I think that's going to have to wait until we get some clarity about some other things. But if you have time, at some point you should invite Daniel Grossamy to come. Daniel Grossamy is a research chaplain at Cincinnati Children's Medical Center, and Daniel did develop a spiritual assessment. The abbreviation is CAAST, And I don't know whether or not it's intended actually for screening as much as it is for assessment. But the important part of that approach to assessment, actually, the CAAST, is that